So, this chapter that we have, first of all, do you guys know, do we have like a universal resource, or do you guys get the BCSC series still by books? Still the books. Alan, do you know, do we have another set of those, like an additional set? Because they updated, if I give my lecture, I think they were, the data is
There's
pretty
like
far.
electronic access.
How do we get
There's
that?
electronic access on OneSource, and
OneSource.
yeah, OneSource has a whole bunch of stuff for residents on it.
Okay.
Well, not the OSU OneSource, the American Academy of Ophthalmology.
Okay.
I guess they're one network. Sorry,
They're
OneSource is
one
OSU,
network,
one
okay.
network is Academy. And the differences in this chapter in the new version versus the old
Right.
version of the BCSEs is relatively small,
Right.
different page numbers, but
Right.
basically still pretty much the same.
Gotcha. Okay, great. So this is obviously it's an interesting chapter. It's an important chapter. Right now, you start getting into that part of the year where your OCAP stuff is really relevant, right? Because you guys are getting close to the, well, not close, but it's closer than you think, because the OCAPs are coming up. So I try to highlight some of that information while at the same time kind of highlighting, obviously, the things that are in the chapter, just to make sure that we are all as much on the same page as possible. Some of this information runs a little dry, so we try to spice it up a little bit, but you know, we'll do what we can. I want to start out, though, first by asking, for everyone that read the chapter, are there any major questions that you have outright that you want us to kind of cover through the chapter? Are there any burning questions, no pun intended, you have about lasers? That was all really just a setup to the joke, to be honest with you. I worked on that all night. But anyway, all right. So there's no disclosures for this particular study that are relevant, but so, you know, going back to the lasers, there's different beliefs about kind of where all this you know, comes from, or where the first indications on this come from. But if you go back all the way to Plato at 400 BC, Plato is sort of given credit with the fact that he recognized that there was this sun-driven damage when you look at the eclipse. And so this is kind of the first allusions to where some of this idea behind light energy having impact on the eyes kind of stems from. And Demos, feel free to jump in here if you've got something to... I don't know if you knew him personally.
Greeks invented light.
Exactly. Greeks invented light. I like it. So, you know, again, sort of a little divergence, but very relevant. When I think about lasers, obviously diabetic retinopathy is sort of the mainstay for a lot of the treatments and things that we come up with for this. And as you guys know, with diabetes, you know, the most common visual loss you're going to get in diabetic issues is going to be diabetic retinopathy. I mean, that's the concern that you have. And again, in the working age population, in especially the developed world, you know, this is an issue. And so when you look at this from the laser perspective, at least historically, it's difficult to eliminate DME, and even with the treatments we have today, and restore their vision back to normal. So diabetes is a huge issue, and the reason it's a huge issue, again, working status individuals, people of working age, the prevalence is 7%. 21 million people in the U.S. have diabetes. That's an incredible amount of people. So this is a huge issue. Although, did anyone read today the what is it? There's a company, I can't think of the name of the company, something site, that has that they have the cure for diabetes. Has anyone seen that? It's an implant that gets implanted into the skin. It's got stem cells in it. It's basically a one-way valve system for the stem cells to produce insulin, and they're now, you know, going forward in their phase 3 trials. They had pretty good success in phase 1 and 2. I thought it was interesting. I don't mean, of course, there's a lot of questions with that because they've had, you know, a lot of testing done in animal models and that, and it works pretty well for animals that live a year. So humans is a whole other population, of course, but there's a lot of excitement being generated around. It was on the AP News this morning. I read that, but so maybe this won't be an issue for you guys, but for right now, it's a big issue. And again, diabetic macular edema is common, right? It approaches 30% in diabetics who've had diabetes for 20 years or more. If you don't treat it, the reason we treat it is you're going to lose vision, and that's the biggest thing. If you do nothing, they're going to double their visual angle in 3 years. That's what we know going back to EDTRS. And so again, I know it seems like something that you hear over and over and over again, but it's for good reason. You have to know this stuff, right? clinically significant diabetic macular edema. What is it? What is the definition? You have to know these three criteria, because if you miss questions on the OCAP like this, that's going to doom you in terms of your points, because you got to get these. These are gimmies. You got to hit them. It's the esoteric third tier questions that you can miss. It's not as big of a deal. But if everybody else gets this question right and you're the one that misses it, that will really hurt your scores. So again, even if you think you know it, it's good to kind of go over it again and put it in your head and make sure that you memorize the three criteria for clinically significant diabetic macular edema. For those of you that took the OCAP last year, did you see any questions on this?
I don't think there was much.
Because the only thing, I wonder about how some of this data does kind of come through. But if you do see it, maybe you don't remember it because it was a
I
gimme.
keyword stuff from the OCAPs for the last few years, and it's on the test.
Yeah. So again, got to know it. But it's funny, Alan, because with all the new treatments and everything, the standards that were the standards now are sort of questionable. I know when we took the exam, anti-VEGF went on there, and it was being used prevalently. So the OCAP does lag sometimes, but you got to know the data. So again, what's the reason that we treat with focal laser? Okay, focal laser, again, has been standard for many, many, many years. And why do we treat? It decreases the loss of vision by 50%. Okay, so it doesn't make vision better. That's not the reason that's treated. That's not the quoted reason. What we know from the data is you reduce the chance of vision loss by about half. And again, standard of care still technically is focal laser for clinically significant diabetic macular edema. It's not the most common treatment, but again, still kind of holds that standard treatment to which the anti-VEGF and everything else is compared. You guys all know focal lasers by now, but again, the key component from this, and this is straight up ECS, you got to know this, it decreases the risk of moderate visual loss, which again is defined as doubling of the initial visual angle by about 50% over 3 years. And that's why we do it. Does anyone know the percentage?
24 to 12.
Correct. 24 to 12. That's great. Sometimes they do. Again, that data will show up in one of the answers. So you reduce the risk of doubling the visual angle from 24% to 12. So that's your 50% decrease. All right, so the elephant in the room is then what about anti-VEGF, right? Why are we even talking about lasers in the world of anti-VEGF? And a lot of this data, again, stems from these two trials, the RISE and RIDE trial, which are kind of basically the main clinical trials that drive our treatment for diabetics with clinically significant diabetic macular edema. And so here's the difference between RISE and RIDE and ETDRS, right? RISE and RIDE looked at what's the increase in visual acuity over 2 years, okay? Not just a small increase, but greater than 3 lines. Anyone want to throw out the data on this? Be brave. I'll even give you you can throw like a number. It doesn't have to be right. Just a range. 20%, 40%, 60%, 80% increase. Sham was 18%. 45% at the 0.3 and 39% at the 0.5. So they're both, if you just kind of think about a general 40% increase, that's pretty good. I mean, you're talking about not just stopping loss of vision, but now increasing the visual acuity, and 40% of those patients responded. That's pretty amazing. And that's why we use anti-VEGFs now to treat diabetic macular edema. So the significance, do you know the significance of the 2 different doses here? So this is kind of an interesting story. So the FDA, when they gave Lucentis basically their approval for diabetic macular edema, the dose, what is the dose that we use in macular degeneration? 0.5, right? So that's the Lucentis dose that we use in macular degeneration, 0.5. So the FDA saw this data and they said, okay, 0.3 works about as well as 0.5. There are these esoteric concerns, which I think are somewhat legitimate, about things like stroke and hypertension and things like that. And so they said, basically, if 0.3 and 0.5 are the same, use a lower dose. So that's why when you guys are given these medications in clinic, in theory, I know that the VA is a little bit of an exception to that, but in theory, you're supposed to be using 0.3 milligram dosage for diabetic macular edema, and the zero point 0.5 for the AMD. So again, just things to be aware of, and it's interesting to see how behind the scenes some of these things play out through the FDA. Okay, so back to what we're supposed to be talking about. So the biggest question is laser obsolete? Javed, do you know what this is?
It's a disc player.
It's a disc player? Oh my gosh.
A vinyl disc player.
Oh, what is it?
A vinyl disc
A
player.
vinyl
They're
disc player.
making a comeback.
They are, right? So this is the point of the slide, right? So vinyl's in a big. I mean, I don't know. My brothers were really. I mean, again, my brothers really were into this. They had record players and they had all the vinyl albums and that. Yeah, and so I just missed that in my time frame. But I saw it. We have one in our house. We play it. But now again, it's making a big comeback. I went into the electric store. We were looking at speakers or something, and they had all these record players. I was like, what is this for? Is this like a decorative thing? I said, no, this is making a comeback. This is real music. And the guy got real excited about it. I was like, I should buy one. I was like, what? No, I don't need one of these. Anyway.
You like the hipster option.
But I'm not. I just be faking it. You know what I mean? Listen, I've got Bitmoji. I feel pretty good about that. But that's only because you guys know who you are. Anyway, so again, and I'll throw a little Star Trek in here. Why not? It's an injection. So anti-VEGF for some people is outright. I mean, you go to some people, and you guys know these patients. They get the injections. You guys are in the VA. No one likes injections. I mean, you don't like to give them. It hurts people. No one likes it. But so there is some real truth to the fact that there are some people that are just going to outright refuse anti-VEGF. So if you do, then again, you've still got laser to work with. There's a cost factor in this, and I think this is going to become more and more and more and more of an issue, especially as all of us get held to quality metrics, right? Because there's going to come a time where, Jay, they're going to look at your clinic and they're going to, well, maybe not yours because you'll be doing something different, but maybe, because yours will be out of pocket, right? You're just doing plastics, is that right? Yeah, so you'll be protected. So maybe for you, Javed, you'll be doing these injections, and they're going to say, okay, it costs $1 million for you to treat a diabetic versus somebody else who's $50,000, and those things are all going to come into play. So there's an important to that. Quality of life's another one. I mean, if you can laser somebody and it stops the edema, and they don't have to see you every month or every 4 to 6 weeks, that's probably got some merit to it. And then of course side effects, infections, and things like that. So aside from just the risk of infection, so there are very real issues that make laser a very legitimate conversation piece. So I'm going to stop there. Somebody needs to answer the question of what the laser acronym stands for. Good. You got to know that because that's an OCAP. That's another one of those give me questions. But it's one of those, if you don't think about it all the time, they'll put 4 different answers that look very, very close to that answer. And so you need to remember the implication by stimulated emission of radiation. Because they have, I remember seeing the OCAP and going, wait a minute. And I remember pausing on it and going, oh God, if I miss this question, this is not going to be good. So remember this, because this will be on there. Did anyone see this in the last couple of years?
It's been on there.
Yeah, I know. It was on my year. I know that. And I just remember having that moment where these all look the same. So just remember. All right. So the physics, all right? This is the stuff that you just got to kind of look at, put it in your brain, burn it in there. It's it's physics, so it is what it is. But the whole point of this is that you have these. Where does this come from? Okay, it's great to have the acronym, radiation stimulated. What's going on with that? So the bottom line is these electrons are in a ground state, okay, and they can, of course, as you remember going back into your physics courses and your chemistry courses, they can occupy a higher or lower energy state, especially if they absorb emission of light. And that process is called radiative transition. Again, that's one of those little buzzwords that sometimes shows up on there. But basically, they get this light absorption, and this stimulates a photon. And the only way they can get to this excited state is if they receive the exact amount of energy. And then there's an electrical discharge component to this, because as these collisions are taking place, and these are accelerated in an electrical field, these move the electrons into the higher states, so then they can release these energy photons. And so all of these electrons want to exist in their lowest possible energy states, And so they attempt to discharge their energy. So they're always trying to get to that lower energy. And again, these photons are discrete quantities which are equal to the difference between the excited and the lower state. And then the spontaneous emission is how these photons are released. The key component to this laser is one atom releases the photon, it interacts with a second atom, that releases a photon, and so you get this compounded effect that leads to the laser energy that's actually applied. And you end up with these two photons, and this is the important part, they have the same frequency, energy, phase, and direction, and that's why the laser is what it is. And so this is, again, I think this is strategy BCS if I'm not mistaken, but again, this is just a diagram showing you get this incident photon. Before the emission, it's in a higher state. The photon hits it, it drops to the lower state. Now you have a second photon that's released when that happens. And so you end up collecting this energy that you can use for treatment. And so the key components of any laser system are basically three parts. You have to have a pumping system, an optical cavity, and a median. And so this goes back to the first Ruby lasers that were done. And basically, you have to pump the energy in, which we just described. That's the power supply that's up there. And then you have this mirror, right? So the mirror is going to continue to reflect all of this energy and light inside of this, this tubing. And then basically there's one mirror on the end that's about 95% reflective. So it's bouncing around 95% of the energy, but it allows 5% to get out. And that's how the energy comes out the one side so you get your beam. Okay? Again, you guys don't have to build lasers for the OCAT, fortunately, but you just have to know the basics behind what's there. And there's multiple types of lasers. So you see different descriptions of what's in there. There's a gas, that's the argon laser that we used to have here and now I think is over at the prison clinic. There's solid state metal vapors, excimer dye, and diodes. Most of the lasers nowadays are diodes. They're chip-based, they're computer, they're smaller, they're easier to transport, and so a lot of the newer lasers are diode lasers. So laser energy in ophthalmology goes all the way back to 1963. Becky, do you know what album this is? This is the debut of the Beatles, was in 1963. That's the relevance of the slide. And what was the song? Baby, help me, please help me. Is that right? I'm blanking on the song now. Anyway, but in 1963, aside from the Beatles making their landing and their debut in the U.S., Kimball et al. Basically described the first clinical ophthalmic use of laser in humans. So again, that's the that time frame that we're looking at. So they haven't been around an exceptionally long period of time. It's a long time, but not in the history of mankind for sure. So then, of course, the next most important thing with laser is how does laser get its effect, and what are the variables that make a difference for laser? So what else? So wavelength, right? We talked about that. Pulse duration. And then this is really important, get overlooked quite a bit, unless you're in a clinic and you're using a laser and you're like, why am I not getting uptake? It's because there's absorption characteristics of the tissue, which are mostly pigment dependent, that really make a difference to get the laser effect. So again, duration, wavelength, absorption, and then of course, media. And again, this is another key one that is really the most relevant clinically when you're treating patients. So in terms of the retinal pigments, does anyone want to throw out some of the pigments in the retina? Melanin, xanthophyll, hemoglobin. That's pretty much the main ones. So the RPE and choroid are where you're going to find your melanin, right? And that's where most of our effect comes from, because you're basically trying to treat to get uptake in the RPE. Obviously, hemoglobin uptakes some of the energy. Why is it, though, that you don't get burns around blood vessels very well? There's hemoglobin there. Why don't you get, these big burns when you're treating around blood vessels? It's flowing, right? There's a cooling effect. It's moving, first of all, and you get a cooling effect from that. So, again, try not to treat blood vessels when you're doing PRP. I want to make sure I clarify you're not trying to hit the red things or the white things, right? That's even more important if you can avoid it. But sometimes you got to do it. The biggest thing for xanthophyll is the blue light, Okay, you want to know why blue light's not on your selection as a laser? It's because of this. Because where's the xanthophyll? Right, and you don't want to treat, especially blue light, or those shorter wavelength lights, because that's the concern. So blue light has gone away as a treatment for that. What's another thing about blue light that makes it difficult to use? Let's say xanthophyll didn't exist. Why would blue light also be? Right. So what does that mean? Yeah, it doesn't penetrate as well. So let's start with the red laser. The red laser is going to penetrate cataracts, and it's going to penetrate blood. It's minimally absorbed by the xanthophyll. So it's a really good laser, especially if you have a choroidal neovascular membrane near the fovea. The red laser is a great laser for that. What's the biggest limiting factor of a red laser? Who's used red laser in clinic? What did you notice about it? Hurts more. A lot more. It's a deeper penetration, so it really, really hurts. So if you switch to red laser and you're using it, your patient's going to go, whoa, that hurts. Now, a lot of times you don't notice it because you're still trying, because most of the time if you're using red laser, you're using it because they've got dense cataract, dense vitreous hemorrhage, and to get through that media most of the time is hard. But, those of you that treat when you're doing these PRPs or what have you, you're treating, and you're like, I don't see any spots, and all of a sudden you see a big white spot show up, and the patient goes, ow! And so you got to remember that, because the two major principles for laser treatment are, and you get out to the periphery. So I don't know that this gets through most of the time, but how many of you set your lasers and then change the settings as you're treating? Right. So you have to do that. If you're treating a laser and you're getting uptake, as you move around and the spots start to get whiter or lighter, you're supposed to, it's not set it and forget it, right? That's not how it works. You don't put it in 200 and then you're done. You turn it up to get your treatment effect. You turn it down when it looks a little hot. So most of the time when you're treating, it's an active process. And I think that really is something that you learn as you go along, as you get more comfortable. But it's an important thing to know. And again, one of the issues you'll find when you have dense media and blood floating around is that you're cranking it up. All of a sudden you'll get a hot spot, and usually that means you've kind of found a spot for the media. So you got to remember to make adjustments when that happens. But when you get peripherally, when you're using especially these lenses, like the super quad and things like that, as you get out toward the periphery, you got to turn it down a little bit because the burns get really, really hot. You'll find that your posterior burns are the hardest to kind of get initially. So if you got a good white burn around the arcades when you're starting your PRP and you're working outward, that's when you got to really start to dial it down, because your patients will start to kind of shuffle a little bit, and you'll know when the burns get really hot. And then infrared is similar, but it's also deeper. Anyway, so yellow laser, I think, for the most part, has kind of become one of the more commonly used lasers that we have. Again, it's low xanthophyll absorption. It can be used for vascular lesions. You get minimal scatter through the cataract. So it tends to be one of the more commonly used lasers. And then green, again, is also well absorbed. And again, a little bit more absorbed by xanthophyll than the yellow, but still pretty good laser. And again, yellow seems to be more the standard laser these days, but green is also very good. So the effects of laser is a really important thing to kind of put in the back of your mind too, because again, this comes up on the OCAPs not uncommonly, and it's a very important concept and very easily overlooked, because you're used to using argon laser, which is what type of laser effect? What's it called? Say it out loud. PRP stands for? So which one of these effects does it use? Thermal, right? So you're used to using thermal lasers. We talk about heat, hot burn, burning effect. Photochemical and vaporization are still part of what you use. They apply to other lasers, but they love to ask this question: what's the effect of the laser? And they'll throw this up, and you're like, aren't they all thermal? I thought they all burned. But you got to remember to make sure to pay attention to this. So photochemical is going to be induced by UV light or visible light. there's usually a photosensitizing medication, and this is verteporfin, this is PDT, okay? So you hear PDT mentioned, and by and large, PDT is not used all that commonly, but it's still used. We still use it. I know Colleen does a lot of it with her tumors. We use it as well. There are certain diseases that lend themselves toward treatment. Some of your patients, again, who are getting anti-VEGF don't want to have any more of those stupid injections. And PDT was used for many, many years for some of those patients. So it is a potential option. It's used in CSR, and then polypoidal is the other big one that you'll see this used in. So it is used. You do need to know it. There's a reason they tell you about it. And the key part for this is cytotoxic free radicals. Okay? Cytotoxic free radicals is a question. I mean, that'll be in one of your OCAPs in your 3 years, I'm sure. Photocoagulation, again, is the one we're most common or most exposed to. You're going to hit laser light's going to hit your target tissue, which most of the time is an RPE. It's a deeper treatment, right? You're going to generate heat, denature proteins. That's the coagulation component to the laser. And you get about a 10 to 20 degree rise, Celsius degree rise in temperature, and that's going to coagulate your tissue. That's going to give you your burn. So again, the idea here is that you're destroying deeper tissue layers. You're getting the photoreceptors. You're going to do what? You're going to improve retinal oxygenation, reduce metabolic activity, inhibit your VEGF, increase your angioinhibitory factors, but you're going to spare the nerve fiber layer. So the whole point of the laser, treat the deep, spare the nerve fiber layer so you can still get signals transmitted through the area, but you're, again, having these important effects by treating the photoreceptor region. We talked about the difference in the treatment. And then this is a really important point. So there's a zone of latent lethal damage that spreads and decays over time. So this is not an uncommon thing to see for focal laser. And this is a very, again, sort of interesting change, I think, in the last few years with treatment and the anti-VEGF and everything else. You see these focal spots, and when you're treating, how big do you guys make the spots in focal? 50 and sometimes 100 if you're using grid. So they're 50 to 100 micron spots. They're very small spots. So you're treating micrograms with 50 micron spots, and you might do a grid of 100. And so then you look at this patient 5, 6 years later, and you see this, and you go, oh my gosh, what happened? The big thing you have to remember is that you're going to get that spread after you treat. So there's a decay and spread of those spots. So you got to remember that when you're treating close to the fovea or even anywhere in the macula, that you could expect to see the spots. So you don't want to get super aggressive with your focal. Again, on fluorescein, these things show up pretty significantly, and you can see them. Some of them are much larger than others. Again, depends on the focus and everything else that we talked about. But what you don't want to see is this right here, right? Focal scar right in the center of the macula, or right in the fovea. I mean, that's when the patient says, I was doing great. Of course, they all say this, but I was doing great until I got that laser, and now I can't see. But this person probably has a legitimate complaint. But everybody says that about their diabetic macular edema, which is one of the things you have to counsel your patients on prior to doing focal is, we do focal laser. We're not trying to make your vision better. We're trying to prevent it from getting worse. Secondarily, PRP lasers. I cannot stress to you guys enough that when you are about to do PRP laser on your patients, you make that as crystal clear to them as possible that this laser is basically trying to stop a process that's already in process and that will get worse even with treatment 50% of the time. So every patient comes in with a vitreous hemorrhage after laser and they say the same thing. I was doing fine until Dr. Minning did that laser on me, and then I got this bleed and now I can't see. So you got to remember to tell them that, because if you tell them that and you say, you're probably going to bleed even with the laser, then when they bleed, they go, oh yeah, Dr. Minning told me that. I mean, this is going to happen.
Just want to make sorry to interrupt.
Yeah, no, please.
But this spot in the center of the fovea, if you see a lot of patients with focal laser treatments, you will see that spot relatively commonly. And I would just be very careful about blaming it on an inadvertent photocoagulation spot. Because people who have had chronic edema or heavy hard exudate plaques in the center of their fovea may have had very excellent focal laser treatment, but after those plaques absorb, or if the edema has been there for a long time and it absorbs, it may leave a zone of atrophy or a little mini disciform scar behind, sitting smack dab in the center of the fovea. And so I would be, if somebody comes to you from another doc and you see that scar, I'd be really careful about what you say because it may not be an inadvertent photocoagulation spot. And I would say most of the time it's probably not an inadvertent photocoagulation scar. It's probably a remnant of chronic edema and RDX state in the fovea. So I just be really careful about how you interpret that finding.
And that's a great point. And honestly, I mean, just to kind of expound upon that, anytime you see a patient and you look in and you go, what the heck did they do to this person? Always in the back of your mind, before any words come out of your mouth, you should give pause to think about what you're about to say. Because to Dr. Lesson's point, you are going to see things throughout your career where you think, what in the world happened to this patient before they came to see me? And you never know the circumstances of what that is and what was involved in that. And it's really easy to look at this and go, whoo, he's right in the middle of that phobia. I can't believe they did that. You know, it's real easy to say that, but like Dr. Lesson said, there's always additional explanations for that, things you're going to be aware of. And even if they did laser in the center of the fovea, you still don't want to be in that deposition having to give that testimony because it's just not worth the time. So, you know, better safe than sorry. And you'll never regret just kind of saying, well, you know, there's things that happen sometimes, and I'm not really sure what the circumstances of this were. You know, all I can say right now is that, you know, that this is where we're at, and, you know, here's how we're going to move forward. And that will be much better for you in your careers and everything else to kind of approach things that way. So, you know, this kind of lends itself to micropulse, so I thought we'd at least just discuss this briefly since we're talking about lasers. Again, not on your OCAPs, it's probably clinically relevant for a lot of you. I think some of you have seen me talk a little bit about the micropulse before. The micropulse is kind of interesting technology. I think there's still a stay tuned tag to this to see how this all plays out. But I know when they first started talking about micropulse, I thought this seems like magical technology to me. And I don't know that I believe anything this person is saying to me. But as I did some background work on it and kind of did some more research, I thought, well, maybe there's something more to this. I still think there's a lot of data left to be determined before we decide whether this is actually real, you know, clinically relevant. But the stuff that's out there is somewhat convincing. And the idea behind micropulse is that rather than treat a laser for a continuous duration of time and let that thermal burn take effect and cause the damage that it causes, the idea behind micropulse is that you kind of go on, off, on, off, on, off, on, off. But most of the time, you know, instead of that, again, whatever your duration is set to for this, rather than it being on the whole time and treating, inside of that duration, let's say it's 0.1 or whatever you have it set to, you're going to get these little treatment envelopes. So it's on, off, on, off, on, off. And the idea of micropulse is these are such small intervals, 100 microseconds. I mean, this is what you're talking about. Very, very, very tiny treatment effects rather than a continuous treatment. And what that does then is rather than you getting this temperature curve where, you know, you slow rise to treatment effect, you actually never really get past this threshold of treatment. And so the idea behind that is you're still creating these thermal changes at a cellular level, but without the thermal negative effects that you get from treatment. And that is the whole concept behind micropulse. Those of you that know, we have one of these micropulse lasers in the clinic. It's in the retina hallway at the end. It's a neat laser. If you ever want to use it, I always tell people, you know, make sure you talk to one of us before you just go in there and turn it on. But there's some familiarity you should have, at least I think, with the laser. It can do regular PRP treatment, which is what we use it for most of the time. But it also does micropulse. This is the study that I think was kind of interesting to me. This came out in Retina back in 2010. And this was prospective randomized controlled trial, 50 patients, 62 eyes. It's a small series, right? This is the thing. But again, untreated center involving diabetic macular edema. And micropulse was as effective as the ETDRS in stabilizing vision and reducing macular edema. The difference was you couldn't tell the laser was done. There was no way with fluorescein, autofluorescence, photos, OCT, you had no evidence that there was any laser done. And so, again, if this pans out over time, that as these series get larger, that this is actually true, I think that's where micropulse has its promise. So,
Dr. Orsi, is this for pathway, that is not like a peripheral
correct.
laser? Okay.
Correct. So this would be so just to clarify, that's a very good question, and yes, the micropulse laser treatment is done for diabetic macular edema, and that has very specific criteria associated with it. But that is their trademark or whatever is micropulse. So when the micropulse is on, that's what you're using that for, and that's what we just talked about. That laser we have also does pattern treatments, which are different from micropulse. So the pattern is, again, somewhat limited, but still continuous treatment burst. And you can make, like the 4 square or 6 square patterns, and you can do PRP with that. And the idea behind pattern laser, not micropulse, I know it's confusing terminology. The difference between pattern and micropulse is the pattern is used for things like PRP. It's done very quickly, it's a shorter duration, so it's supposed to be more comfortable. And I don't know, Alan, how much experience you have with the pattern here, but in my patient population, night and day. I've done lasers, over at Dublin, PRP laser, and then had them come over here and they get their second laser done, and I've done the pattern laser, and they're like, oh gosh, this laser is so much better.
So does the pattern do like multiple at the same time?
Right. So when you push the pedal, like for right, you can set it to different patterns, but let's say for instance it's 4 dots. So it's basically like a square of dots. You have one in each corner, and then you push the pedal and it goes, brrr, and you can do 9 and go, brrr, and it treats like that. That's the noise it makes. But yeah, I mean, so it's nice because rather than going dee 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 dee, you go brr, brr, brr. So basically, you can reduce your PRP time. I mean, my PRP time significantly decreased when I started using the pattern. I mean, by and large, because again, it's not just spot, spot, spot. You're getting a whole bunch of treatment, and you can use them around breaks and things like that too. There's little fancy ways of doing it. But the main two uses. Or the main use for the pattern is, getting through your PRP a little faster and make it a little bit more comfortable for your patient.
It's a difference of 20 to 30 minutes
Yeah.
versus 5 minutes.
Yeah, it's fast.
Yeah.
So it's nice. It's a nice treatment.
Does that setting cause scarring?
Yeah, no, that's what you're looking for.
That's exactly.
Yeah. So again,
It's continuous wave laser,
Okay, it's
thermal,
continuous wave.
exactly the same.
Yep. They tweak the duration just a little bit, so you're not getting that full dot treatment that you would get when you do single dot spots. But it's still the same criteria. It is not, clarify this as much as, it is not micropulse.
For this micropulse thing then, do you just treat what you see that's like the pathology since you can't see your laser?
So great question. So the actual treatment itself is a 7x7 grid of dots. There's no spacing between them. And again, we can kind of go over what's involved with that. Before you ever do a micropulse, again, you should talk to one of us before you do it because there's very specific criteria. So it's basically a confluent 7x7 grid of these dots. And I'll tell you what the company says you're supposed to do and what I do, all right? So technically you're supposed to, let's say you've got, this pattern of macular edema, okay? So you look on your OCT and you say, okay, so my edema's right here. You're supposed to take this grid of dots, which it's not quite to scale, but it'll look something like this, right? You'll actually see the grid. It'll show you all the 7x7 dots. There'll be this red thing confluent across, and you're supposed to treat 1, 2, 3, 4, right to the fovea. Don't sweat, they say. I still haven't come to that point where I feel comfortable enough treating through the fovea, so I do sort of a modified version. Of course, I know I've got my edema right here. I'm going to treat 1. I do the corners, 2, 4, and sometimes I'll kind of overlap a line here, but again, still avoid the fovea. That being said, and this is what they tell you, the patient's going to move a little bit from time to time. I have definitely had the laser go into the fovea before. I'll admit that openly, but it doesn't affect them. I mean, that's the thing, and that's what they say. After you do a number of these and you see that the fovea gets treated every once in a while and your patients don't have any change in their vision, then you'll start to treat to the fovea. I still haven't done it. I don't necessarily recommend that for anybody who's doing it yet, but again, once you do it the first time, you kind of see what it's like. It's not so bad. But their argument is because it's such a lower treatment, you have to have much more spots. So again, you would never do that with focal laser. Never. But micropulse is different. And again, this is showing the micropulse treatment versus the ETDRS, and this is 1 year post treatment. Here's the grid treatment that was done to this patient. Clearly, you can see where that was done, and here's your micropulse laser a year after treatment. Both of which, the edema went away. Although arguably, this is not quite as impressive edema as this is. But again, you don't see that the treatment is there a year later. So interestingly enough, there's a lot of studies being done on some of that stuff right now. Right now, the answer to that would be no. You wouldn't use it for AMD. You wouldn't use it, so for choroidal neovascular wet macular degeneration, choroidal neovascular membranes, you wouldn't use that at all. There's an argon laser, there's a specifically defined criteria for treatment and use of that. And full disclosure, most physicians do not use argon laser for choroidal neovascular membranes and wet macular degeneration anymore because it leaves a big scar, and we have anti-VEGF and PDT. So your first 2 lines before you even considered something like that would be anti-VEGF and maybe PDT. That being said, histoplasmosis, I think, and Alan, you can comment on this, maybe you might consider it, but even that, most of the time, you're still treating anti-VEGF first line. Again, histo might be the one consideration where if it wasn't responding to anti-VEGF, or you had a very nice, well-circumscribed, juxtafoveal lesion, or extrafoveal, yeah, exactly, even better, you could consider treating with argon laser. But for the most part, you're not going to use laser to treat macular degeneration. I'll make that clear point, and then say, though, you may be referring to the fact that there are people, there's actually a study being done right now looking at people who are high-risk dry macular degeneration. If you treat them with low-dose laser, could you potentially decrease their risk of converting to wet and things like that? But that stuff is all, just forget I said, I mean, it's all out there being looked at. So, for the most part, you do not treat wet macula with laser. Very good. Real quick, I'll just skim through this. I know we're running low on time, but the micropulse overview. When you look at them, this is what the laser looks like. Okay, so if you go back to the machine, you say, okay, what's this? The most important thing right here is this right here. Okay, this is their little trademark micropulse. This is the most important thing you have to look at when you look at this laser. This micropulse off or micropulse on. Because if you decide you're going to do micropulse and you get all your parameters set in there, but you don't look that this thing is on, you're going to wind up in a court somewhere having to defend yourself on it, okay? And I can't stress that enough. You have to look at the micropulse. That being said, if you're doing something else and you're like, why am I not getting uptake? You might want to look at that button too, but that's a much easier situation to recover from than the other. So anyway, this is the T cell, which is on top. This is how these deformable mirrors that allow you to get these patterns done. But this is where you're going to see your spot size, this big dial up here, which is a little bit interesting. And then you've got this little X. Basically, you're going to be able to, if you look in there and your dot is all the way off to the left or right, you can still get that dot in the center of your light beam when you're looking in there using some of these controls. So this is your X-axis control, and we'll come back to that in a minute. Again, you like the finger? Make sure your micropulse is on or off depending on what you're looking at here. Once you do that, you can then turn the dials. This is going to be turning your duration. So we're changing the duration with this knob here on the left. The middle knob is going to change your power. And then this knob here is going to change your interval, okay? It's also touchscreen. So it's as confusing as possible because it's both. Because you have to turn dials to turn some of them, but you can click on other ones. The buttons you push on the screen, but the knobs you use to turn your duration. It's a little confusing. Again, if you want to use pattern, you would click on pattern. And then you get all this sub-menu here that you hit OK. And then this is your grid. So you're looking at, you've got the ability with this knob to change your rotation. You can change your grid pattern to different densities. So this is a 6x6 grid. And then your spacing for this, in this particular example, is one spot size of spacing. So these are, you get a space between each one of these spots. So again, you change your spacing by rotating that. You saw the grid got bigger when I turned the spacing to 1.5. And again, you can rotate it, so now you got a diamond shape as opposed to the actual square shape. there's all kinds of neat little things you can do with this. Again, circles another one you can do. Like if you had a tear and you want to circle the tear, you can do that. You can make it confluent. So anyway, that's the pattern. Again, back to the micropulse. When you click the micropulse button, this is what you end up with. And if you're setting micropulse to do diabetic macular edema, you would click it on, and then you would do a 5% duration. That's the actual percentage you would use. Some of these others are actually used for glaucoma, but the 5% duty cycle is what you want for diabetic macular edema. And then again, you've got your spot size up here. This is if you want to change, again, that laser spot's not lined up. This is your z-axis. So again, you want to be aware that's that. And then they hide the y-axis. I don't know how long it took me to figure this out, but I remember like I can't move it up and down. And it's right on the side. You look over here. You can kind of move this little lever and it moves things a little bit. But if you look real close right here, we'll zoom in on it. There's the y right there. And I think it's actually engraved on there Y, but you really have to look pretty close to see it. But just so you know, you can change all those things. So if you ever look in and your red dot's all the way over here and you're like, what's going on? You got to get it back in the center before you treat. Again, real briefly, we'll just look at lens types. I mean, there's basically the two types of lens I talk about in your BCS. You know, negative power plano concave and your high plus power lenses. Again, your negative power plano concave, they love to ask these questions. Upright, equal, magnified, inverted, like they love those 4 questions they can get out of one of these things. So your negative power plano concave are going to be upright and the spot size is going to equal your laser. Your high plus power lenses are going to be inverted. So those are the ones where you look in and you go, wait a minute, what's going on here? And then they're magnified, but they're usually wide field. So like your Mainster, I think you guys use this, the Mainster 165, the VA. Your spot size magnified by 2. And then, you know, what are the complications of the lasers that you need to be aware of? Unintended damage, obviously, is the big one we've kind of stressed a little bit here today. But your thermal damage to your long ciliary nerves leading to your pupil, this is a big issue. Okay, you really, 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 really got to think about this. The big, long, white things that you see here, don't treat those if you don't have to. Because what happens is patients get a lot of issues with their pupils afterwards. One pupil may be asymmetric, and that drives people nuts. Worse than that, they can't focus when they go from light to dark. So it takes longer for them to adjust, and that's what they'll tell you about. And you know, you're like, oh, it's diabetes. But you know, but the bottom line is that, you know, yeah, sure, it's related to diabetes, but this is the problem, right? Don't treat the nerve because that's what's going to happen. Sometimes you have to, and I'll tell you, we just had this Tuesday. Like 2 people came in with horseshoe tears, or where are they at? They're right on the nerve. You got to treat them. You can't do anything about that. Like, sorry, it's going to hurt a little bit. People's going to be funny, but you got to treat that because you know the retinal attachment's not going to do you much good anyway. Lens absorption can lead to cataract. Again, not so much with the longer wavelength light, but just something to be aware of. And again, if you're treating in and around the disc, the optic nerve, you can get an optic neuropathy from that. So just remember that. The other thing, if you're ever treating with PRP and you hear a noise. And I remember people describing this to me at one point. It's like a little psst. And usually the patient hears it too, and they're like, what was that? You're like, oh, nothing, you're fine. The second time you hear it, you should probably stop what you're doing, turn your power down a little bit. But this happens, especially sometimes with the shorter duration, which can happen in pattern scanning, or the pattern lasers, because they do kind of lower the duration. But you get this high energy, low duration laser, and it's kind of like that's the effect of laser. It hits hard and fast. And you hear a little pop, that's a rupture of Brooks membrane. Okay, and again.
So when you so you're doing the pattern, do you do like one test shot to make sure that
Oh yeah.
you know everything's fine
Yeah.
before you do the
When I do pattern, what I'll do, again, I start posterior.
Yeah.
And I want to get, so let's say you're doing PRP. I mean, this is a good review. You're doing PRP, I got to get a white spot.
Yeah.
That's what I want in PRP. Now, it doesn't have to be hot, hot white. But that like faint gray spot is not what you're looking for in PRP. Faint gray, barely visible, focal, right? Makes sense because you're treating around the macula. White spot, you want to get treatment, especially your retinal tears, but PRP as well. So I look posteriorly, and I'm going to have my highest energy posterior around the arcades when I first start. So I get that, relatively white spot, and then I treat. And I usually go around and make a square, and then I treat out from there. But as I go out and I see the white start to get a little more intense, that's when I turn my power down while I'm treating. So I'll be going, boop, turn down, boop, and just try to keep that uniform white. But occasionally, no matter what you do, again, you're going to get a spot every once in a while. Ooh, that's pretty white, and hopefully you don't hear the pop. But
It'd be bad if you got 9 pops.
right, yeah. But I mean, I remember the first time that ever happened with me. It was as a pattern laser, and the patient was like, "What was that?" I was like, "Oh, what was what?" Because I wasn't sure if I heard it either. I was like, "Did I hear something?" And I was like, "No, no." And then I was going along again, and the second one I definitely heard, and I was like, "Ooh." I turned the laser on. He's like, "What was that?" And I was like, "Well, sometimes when the laser is a little hot, it can cause a little bit more of an effect than we're hoping to get." Um, he did fine, but you're always worried about crude neovascular membranes forming from there. You can get bleeding, so it's not. You don't want that. Try to avoid that. The other thing is, if you have a patient calls in after PRP, and they call up and they go, "I'm in pain," bring them back in, especially in the first week. Because you can get, especially if you've done an extensive, a lot of PRP, you can get this choroidal detachment, serious choroidal detachment after you do the PRP. It can hurt, it can throw them into angle closure, it can be bad. So even though most patients that call with PRP are fine, they just need to take some Tylenol, they'll be okay, this can happen, so you need to be aware of that as an effect of the laser. Again, you can create full thickness retinal holes. The fellows can tell you all about that when they're lasered in surgery, but that's usually when you see it is when you're in surgery. But you can do it in clinic as well, and if you do it, then you got to put more laser around it and surround that hole. But your biggest worry is you're going to get a neovascular membrane or some sort of scar tissue in that area. You can create RPE tears and all sorts of wonderful things. Real fast, I'll shoot through PDT and then I'll stop. So PDT, again, just as kind of a refresher for you guys, this was really popular, 15 years ago, maybe a little bit, around that time frame when we didn't have but argon laser to treat wet macular. And basically in PDT, these patients are treated with verteporfin. Verteporfin is absorbed systemically, and basically the idea is it's a dye that is activated by a quote-unquote cold laser. So if you just shot this laser into somebody's eyes, nothing would happen. But when you have verteporfin in the system, the verteporfin is supposed to collect in cells that are rapidly dividing and endothelial cells, and especially in cells where there's new blood vessel growth, it tends to collect there. So that's what the dye does. And then the laser activates it where it's concentrated in this choroidal neovascular membrane, and that's where you get this effect. So again, subfoveal choroidal neovascular membranes in histoplasmosis, pathologic myopia, these are kind of some of the things people still use it for. The classic treatment for this is if you had subfoveal, predominantly classic, choroidal neovascular membranes and AMD. Some of you may go, what are you talking about, classic versus non-classic? Again, it's a whole other discussion. But this is what it was generally treated for. And then there was also some use for it for a cult with no classic. And again, this is less important now, but it's something you should be familiar with because sometimes these things do pop up. Again, doesn't need heat, doesn't photocoagulate. Again, the laser excites the drug into a higher energy state. You get these free radical formations around the area, which causes endothelial damage, platelet adherence, vascular thrombosis, and then capillary closure. So the idea is you're basically clotting off the membrane, but not damaging anything else. What are the complications? And I think these are things to be aware of because, again, this will sometimes show up on UroCaps. You need to know about the photosensitivity reactions, right? So, you can get mild to second-degree burns if you go out in the sun after you've had verteporfin infusions. So you got to tell patients, I think the insight or the insert says like 5 days. Most people say 2 to 3 days. You got to stay in from the sun. Don't go outside, especially when it's bright and sunny outside. Wear hats, sunglasses, the whole 9 yards. And then this back pain, side and chest pain, which happens at about 2 to 2.5%. And then there's a severe vision loss that can occur within a week of PDT, thought to be a choroidal infarction, that can happen, not uncommonly. I mean, it's not common, but something to be aware of. So patients can have it, which is why a lot of us don't use PDT that often because, again, you're always worried about it. You've got to make sure patients know that before they get treated. Correct, but it's a huge spot actually. Like when you're treating, you take the lesion size, largest dimensions, and then you might add 300 to 1,000 microns. So your spot is basically the whole macula when you're treating a lot of these lesions, not all of them, depending on the size. But I mean, basically, when you look in, you'll see a green dot, which is a red dot, which is your aiming beam, and the red dot will look like it's taking the whole macula. There's a whole method to using PDT laser. The idea is again that the drug is collecting in those vessels that are the new vessels, and the rest of them, just like your rest, it's just kind of flowing through, so it doesn't stick. But that's the reason that we worry about this choroidal infarct, because what you said is true. I mean, it's obviously in those vessels. It is somewhere, but the collection of the dye, where it's adherent, where it's concentrated, is in those new blood vessels, and so that's the theory behind its treatment effect. Good question. That's it. Any other questions? Yep. Thank you. Hit stop. I don't know how to do